So the name the test shown for inguinal hernia. So now we are going to see the basics in hernias. So these are very basic concepts. You should never have a doubt in the basics. So the name the test shown in the hernia below. So the picture below shows a very important test called as finger invagination test. Please remember, this test cannot be done for females. It can be done only for males. Grasp the scrotal skin, and usually you should put a little finger, not the index finger as shown here. Go with the little finger into the superficial ring and into the canal. Put the finger through the canal and examine the canal. So when I am putting the finger like this, I ask the patient to cough. If I feel the impulse on the pulp of the finger, it is called as direct hernia. If I feel the pulse in the tip of the finger, it is called as indirect hernia. This test is abandoned due to discomfort for the patient. Now we are not advising the surgeons or the students to do this test. So if the hernia is felt in the pulp, it is direct hernia. If the impulse is felt at the tip, it is indirect hernia. The only advantage of this finger invagination test is it tests the posterior wall weakness. It can test the posterior wall weakness can be tested by this finger invagination test. Okay. So this is a very important test called as deep ring occlusion test. Deep ring occlusion test. DRO, deep ring occlusion. So make the patient lie down, reduce the hernia and identify the deep ring half inch above the mid-inguinal point and keep your thumb compressed on the deep ring. For example, if this is the deep ring, compress it with your thumb like this and ask the patient to cough. If the patient is coughing, if direct hernia, hernia appears. In a direct hernia, hernia appears. In an indirect hernia, hernia not appears. That's all. Hernia not appears in indirect hernia. So where are the patients you can get indirect hernia, but hernia appears. Indirect hernia, but hernia appears. Hernia appears in which are all the indirect hernias. So indirect hernia where the hernia can appear back again is number 1, dilated deep ring. When the deep ring is very much big size, when the deep ring is very much big size, it can appear again. Big size deep ring, it can appear again. Number 1, because you cannot compress the entire deep ring with one thumb. So dilated deep ring. Pantaloon hernia. There is a direct as well as indirect hernias. You can have the thing appearing. So number 3, you have not done properly, faulty technique. You have not compressed the deep ring correctly. So faulty technique, pantaloon hernia, dilated deep ring, all these are indirect hernias, but it can appear. It can appear. Hernia can appear in indirect hernias. Usually in indirect hernia, hernia will not appear. Where are the places in indirect hernia the hernia appears is dilated deep ring, pantaloon hernia and faulty technique. Okay, don't forget this. And in deep ring occlusion test, femoral hernia also appears. Femoral hernia is different, no? So it will appear. So which all hernias can appear back is direct hernia can appear back, femoral hernia can appear back, pantaloon hernia can appear back. So the 3 hernias which will appear back on deep ring occlusion test are direct, femoral, pantaloon. Indirect hernias will usually never appear. This is 3-finger technique called as Zieman's technique. Zieman's technique is 3-finger test. So you have to keep the 3 fingers. One finger is kept on the deep ring. Okay, this is a deep ring. Another finger kept on superficial ring. Another finger kept on saphenous opening. So at that time you should keep 3 fingers like this. Okay, 3 fingers are kept in 3 openings. And ask the patient to cough. If the impulse felt at deep ring, it is indirect hernia. The impulse felt at superficial ring, it is direct hernia. The impulse felt at saphenous opening, it is femoral hernias. So don't forget these 3 hernias, indirect, direct and femoral. According to the impulse, we have 3 different hernias, indirect, direct and femoral hernias. So this is a very basic 3 tests. Don't forget deep ring occlusion test, finger invagination test and Zieman's are clinical tests used in hernias. And another basic thing which you should not forget in hernia is meshes used in hernia. These are all very basic concepts. You should not have any doubt. There are two types of mesh. One mesh which will be netted, like small holes will be seen. This is a typical netted mesh. Another mesh will have no small defects and it will be like a flat sheet. So flat sheet mesh is usually not used nowadays. So we are only using net mesh having pores that allow when I am keeping a pore, the tissues will grow in between the pores and will hold the mesh and allows the native tissue ingrowth and becomes integrated into the host tissue. This is a net mesh. Whereas a sheet mesh is different. Sheet mesh will not allow the tissue ingrowth. And since the tissue ingrowth will happen and hold the mesh, no need of fixation in case of net mesh. No need of fixation with the sutures or tackers. But in sheet mesh, you have to need a tackers or sutures are used. Tackers or sutures are used for sheet mesh. So lightweight and heavyweight mesh. Lightweight mesh is 40 grams per meter square. Heavyweight mesh is 80 grams per meter square. So this lightweight mesh has a large pores, less shrinkage, better comfort and better tissue integration. Better tissue integration, better comfort, less shrinkage. Whereas heavyweight mesh is having more shrinkage and painful. Therefore, heavyweight meshes are not used nowadays. So mostly we use mesh which are 80 grams per meter square or less. We use a net mesh. So net mesh, lightweight mesh is what we are using in practice. Net mesh and a lightweight mesh is what we are using in practice. And similarly, there are two types of mesh. Synthetic mesh and biological mesh. Biological mesh and synthetic mesh. Synthetic mesh commonly used is non-absorbable Prolene mesh, polyester, polytetrafluoroethylene. These are all various meshes. So in this, you should never forget Prolene mesh is hydrophobic. Hydrophobic means it resists the bacteria entering to the mesh. So it resists bacterial ingrowth. It will not allow the water to come inside, so it resists. Hydrophilic can encourage microvascular ingrowth. So can resist microvascular ingrowth, but polyester meshes are all not commonly used. The commonly used mesh is Prolene mesh. So polytetrafluoroethylene is a flat sheet, as I told you, flat mesh and inert to tissue ingrowth and adhesion formation. We use PTFE mesh whenever we feel there may be an adhesion, but they are also less commonly used. And we have nowadays absorbable meshes made up of polyglycolic acid, collagen and polyhydroxybutyrate. They are all not used in hernia repair. Please remember, absorbable meshes are not used in hernia repair. They are used in temporary abdominal closures and if there is a suture made to strengthen the suture line. That's all. Otherwise, absorbable meshes are not used in hernias. So the most commonly used mesh is Prolene mesh. Biological meshes are just provide a scaffold to encourage neovascular ingrowth, fibroblast proliferation and collagen formation. They get rapidly destroyed in infection and should not be used in infection. So biological mesh are just also used as a temporary closure of the abdomen. For example, an abdomen which is opened up, we have discussed like burst abdomen or any temporary cases, wound is having a big gap, we keep a biological mesh like this. We keep a biological mesh like this and it will naturally get absorbed along with the body. So they are rapidly destroyed in infection and you should not be used in incisional hernia repairs. You should not use a biological mesh. So what are all the biological mesh? Bovine pericardium, human dermis, porcine intestine submucosa. So it's a porcine intestine submucosa. All these are called as biological meshes. So remember the golden rule. Prolene non-absorbable mesh should not be exposed to the abdominal contents like bowel, as they can cause dense adhesions to the bowel, and only absorbable mesh should be exposed to the bowel contents. For example, this is abdominal content. If I use a Prolene here like this, the bowel and all will come and adhere to this and cause severe problems. So bowel adherence can happen with the Prolene mesh. So don't use Prolene mesh in the abdominal content areas. So don't forget. Therefore, in such places, we have a mesh in which one side is made up of Prolene like this, another side is made up of an absorbable content like this, inner side. Towards the abdominal side, towards the bowel content side, we can use a polycellulose. or polygalactic acid, that is vicryl, and this side is Prolene mesh. This is called as a dual mesh. Outer side is towards the abdominal wall. Okay, this is towards the abdominal wall and this is towards the peritoneal side. Okay, towards the abdominal cavity is made up of, this is peritoneal cavity is made up of polycellulose, towards the wall is made up of Prolene. This is a typical dual mesh. So I want you to understand the concepts of mesh. Please understand the concepts of mesh. I am going to show you the various layers of abdomen. This is the skin. Okay, this is skin. This is the anterior rectus sheath. This is anterior rectus sheath. So anterior rectus sheath. What are the layers then? This is external oblique muscle. Okay, remember this is external oblique muscle. This is external oblique muscle. What's the next muscle is? The next muscle is internal oblique muscle. This is internal oblique muscle. This is a linea alba center point. This is internal oblique muscle. Then comes the rectus abdominis muscle. This is rectus abdominis muscle. Sorry, this is transversus abdominis muscle. So don't forget transverse abdominis, the external oblique, and this is internal oblique. And comes the most important layer. All of you know what is this layer? That is the most important layer called as fascia transversalis. And then comes our important basic layer, that is a peritoneum. This is peritoneal layer. And here there are bowel contents. Please remember, these are the bowel contents inside. So hernia is nothing but something coming out like this, through this place, there is a hernia coming out. So now I can keep mesh in three methods. Method number 1, I can keep a mesh just below the skin on the anterior rectus sheath. This mesh method is called as onlay mesh. I am telling you all Prolene meshes. I am keeping Prolene mesh, onlay mesh. This is an onlay mesh kept on the anterior wall, on the top of the muscle or fascia in the subcutaneous space is onlay mesh. This is onlay mesh. And once upon a time people used one mesh called as inlay mesh, which is kept into the defect like this, which is no more advised. It is inlay mesh. It is abandoned because it is not going to cover the defect in a wider way. The concept is, if there is a defect, you should cover it 2 to 5 centimeter all around. So mesh should cover a defect 2 to 5 centimeter all around. That is a rule. If there is a defect, it should cover. This is a defect means I should keep it 2 to 5 centimeter on all around. So therefore inlay mesh is kept within the defect, is no more used. It is because it can cause more chances of recurrence. Therefore it is abandoned. Then came a very interesting mesh called as sublay mesh, deep to the muscles in the abdominal wall like this. It is one sublay mesh. Sublay is of many types. This is a sublay mesh. This is sublay mesh which is kept extraperitoneally, and this is sublay mesh which is kept intraperitoneally. Please remember, intraperitoneal sublay mesh. This is extraperitoneal sublay mesh. I already told you what should never be done. Intraperitoneally, I should not keep Prolene mesh. If I keep Prolene mesh intraperitoneally, what will happen? It can cause adherence of the bowel. Therefore, extraperitoneal mesh is preferred, which will be kept in between the muscle layers as shown here. Never do intraperitoneal mesh due to risk of adhesions. Don't do intraperitoneal mesh due to risk of adhesion. So this is from Bailey and Love. This is onlay mesh above. This is sublay extraperitoneal. This is sublay intraperitoneal. Sublay intraperitoneal should never be done. Don't forget, as of now, these are all discussions for Prolene. So there came a new operation now called as I told you, this is a fascia transversalis. This is peritoneum. See, now I am going to show you a new method of mesh in which I keep a mesh which is dual mesh. One side made up of Prolene and another side made up of vicryl or polycellulose. This is a very costly mesh. It will be costing around 25,000 rupees. It is a dual mesh which I can keep it by laparoscopy. During laparoscopy, these are all bowel means. In an incisional hernia like this, if there is a hernia here like this, I can keep a mesh. This is abdominal wall. I can keep a mesh like this from inside. This surgery is called as IPOM. It is laparoscopically done. Intraperitoneal onlay mesh. This is our latest treatment of choice for incisional hernias. So the treatment of choice for incisional hernias from Bailey and Love is IPOM. Intraperitoneal, I can go and keep it inside like this. I can keep the mesh from inside called as intraperitoneal onlay mesh. It is usually done with only dual mesh, which is a very costly mesh. Okay, dual mesh. So don't forget intraperitoneal onlay mesh. It's a very basic concepts. You should not forget about the basics of mesh repairs. Okay.